just after 1 o'clock, so we'll get started with our webinar this afternoon. Today, we're looking at rainbow realities, an in-depth analysis of large-scale LGBTQA plus health and wellbeing data in Australia. Thank you for joining us this afternoon. My name's James Zanotto. I'm the Director of Policy, Research and Communications here at LGBTIQ plus Health Australia, and my pronouns are he, him. LHA acknowledges the traditional owners of country throughout Australia, their diversities, histories and knowledge, and their continuing connection to land and community. We pay our respects to all First Nations people and elders past and present, and I particularly pay respects to any First Nations people with us today. And I'm joining you from the land of the Gundungurra people in the Southern Highlands of New South Wales, and I particularly acknowledge them. I invite you to share the land you're on today in our chat function. So as we begin, I'd like to mention just a couple of housekeeping items. Today's webinar is being recorded and will be available to members on the LHA website afterwards. So if you miss anything, want to have another listen, you'll be able to find it there within the next week. After our discussion, I'll invite an opportunity for some questions. So please use the Q&A function. Typically for most people, that's at the bottom of the screen towards the left-hand side. And we'll pick up as many of those questions as we can after our presentation today. And if there's anything in today's webinar that raises concerns for you, support is available. You can contact QLife, which provides Australia-wide anonymous support for LGBTIQ plus community on 1800 184 527 or visit qlife.org.au. Now, on to rainbow realities. It's a really important piece of research which synthesizes pre-existing findings with 50 new analyses, bringing together data from Private Lives 3, Writing Themselves in 4, SWASH, Trans Pathways, Walkern Katatdjin, Rainbow Knowledge, and Pride and Pandemic. In total, around 20,000 responses were received for these surveys from LGBTIQ plus people, spanning all parts of Australia and a wide range of intersectional backgrounds. It is important to note, though, that despite efforts to collect data from participants with intersex variation, there was a relatively small sample size of participants with intersex variation in the surveys. So as a result, today, we'll generally be using LGBTQ+, acknowledging that we don't have sufficient research on people with intersex variation to include in this report. Rainbow Realities was commissioned by, was overseen by LGBTIQ plus Health Australia with a co-designed input from LHA membership. It was commissioned by the Commonwealth Department of Health and Aged Care to inform the development of the 10-year LGBTIQ plus Health and Wellbeing Action Plan. It was also an extraordinary research partnership between the Australian Research Centre in Sex, Health and Society, ARCSHS, at Trobe University, the University of Sydney, Telethon Kids Institute, and the University of Western Australia. And I'm particularly excited today to have 4 of the best in Australia who worked on Rainbow Realities to present the report to us. First up, I'd like to introduce Dr. Natalie Amos. Nat is a research fellow at the Australian Research Centre in Sex, Health and Society, ARCSHS, at La Trobe University. We have Professor Ashleigh Lin, who's an NHMRC Emerging Leadership Fellow and Senior Principal Research Fellow at the School of Population and Global Health at the University of Western Australia. Also, Shakira Lidlow-Hunt, Shak, is a Wajari Yamajitra, sorry, I tried. I'll let you do it properly when you get to it, Shak, who grew up in Noongar country. They're a research assistant in the youth mental health team at the Telethon Kids Institute and PhD student at University of Western Australia, focused on the mental health and social and emotional well-being of Aboriginal and Torres Strait Islander LGBTQA plus young people. And finally, I'd like to introduce Associate Professor Julie Mooney-Somers. Julie's Associate Professor in Qualitative Research in Health at the Sydney Health Ethics, Sydney of Public Health Facility of Medicine, University of Sydney, and a visiting fellow at the Australian Centre of Health Engagement, Evidence and Values at the University of Wollongong. So welcome. Thank you all, Nat, Ashleigh, Shaq and Julie. A reminder to everyone here on our webinar today, please put any questions into the Q&A function and we'll come back to them at the end of the presentation. And on that note, I would like to hand across to Ashleigh, who will begin our presentation. Thank you.
Hi, everyone. Thanks for having us today, James. I'm going to share my screen. Could I just get a thumbs up from one of my panelists that you're seeing the right thing? Perfect. Okay, so I am going to talk a little bit about the introduction to Rainbow Realities, but I will start, my computer will work, by acknowledging that we're all meeting on Aboriginal and Torres Strait Islander land, wherever we are in Australia. I'm on the lands of the Whadjuk people of the Noongar Nation. And we've just moved into the Dilbar season, which is represented by pink and is around, which represents the wildflowers starting to come out. So we can start seeing them peeking out through some of our wonderful bush over in WA. I'd like to pay my respects to elders past and present. James has already said a lot about Rainbow Realities, so I'm not going to repeat it all, but really the idea was for us to bring together all the surveys that we already had rather than collecting new data to try and inform the national plan. We wanted to use what we already had because often our studies are funded to collect the data and then we get a few papers out of them, but there's so much data in all of them that previously hasn't been looked at. So I think particularly we have to thank Nat, who gave up 6 months of her life to put this together. But all of us have been working really hard to bring together Rainbow Realities, and I think we're all very proud of it. So what did we really want to know? What is the nature and the extent of need? What are the risk and protective factors that are associated with health outcomes in LGBTQA plus populations? What are the association between different outcomes and experiences? And what are the factors associated with health service engagement and experience? We have these surveys, which are all kind of beautifully presented surveys, which I'm sure most of you have already seen. And they go from 2017 all the way to 2023. As James said, we don't have much data from people with innate variations of sex characteristics, but I would like to highlight that Morgan Carpenter and the team have recently got funding for an MRFF project, a big consortium which we're involved in, which will do this kind of work for people with innate variations of sex characteristics, which is so desperately needed. So you can see all the different populations that are represented in our surveys. Some are youth specific, some are adults only. And what's in the report? So the report is 10 themes, it's divided into 10 chapters, and these are what's in each theme. So we've got a big theme about mental health and suicidality, housing, abuse and discrimination, and then family violence and sexual assault. We've looked at alcohol and other drugs, sexual and reproductive health, gender affirmation, healthcare. Then we've got a section on Aboriginal and Torres Strait Islander people, and then other intersectional communities. And the way that the report is structured, if you haven't seen it yet, is we introduce the topic. We then look at what the findings were that are already published. So what we already know from each of those studies in relation to that topic. Now, for some of them, there won't be any published data on that, but anyone who had some data on that topic was then included in that chapter. So a summary of the findings so far, where they've been published, so you can link to those. And then we've done the new analyses of data that has not previously been published in academic papers. And then each chapter ends with a summary of what was discussed. So we think it's really user-friendly, and I hope you do too. So the way that we are going to do this webinar, that is pretty much all from me. So I got the really easy job this time. So what we're going to do is we're going to go through all the speakers. I'm going to move the slides. Everyone knows that that's a risk, but we're going to try our best. And we are going to each talk about some of the data from the studies that we led. So without further ado, I will hand over to Nat.
Thanks, Ash. So I'm going to provide a bit of a snapshot of findings from across a few different chapters of the report. There were something like 52 new analyses that were reported. So I've just cherry picked a few that I don't know, felt relevant, some of my favorites. So this first one, there are several analyses included in the report that reflect on health service experiences as well as preferences of health services. So this one of these analyses looked at engagement with mental health supports among young LGBTQA plus people who indicated having a need for support at some time in their life. So these analyses were based on the data from our young people survey, the Writing Themselves in 4 survey. And what we found was a really staggering 84% of these young people reported having ever experienced suicidal ideation, ever attempted suicide, or self-harmed in their lifetime. And we then used this as an indicator of a need for mental health support at some point in their lifetime. Among these young people, more than 1/4 had never accessed any mental health supports. And also a concerningly low proportion, less than half of them who had accessed mental health supports actually felt that these supports had helped to improve their mental health in some way. Specific subpopulations were particularly disadvantaged in these domains, and they included cisgender women, non-binary people, and those who did not feel supported by their family. And they were all less likely to feel that the mental health support that they received had improved their situation. Next slide, please, Ash. Thank you. So theme 2 in the report was dedicated to experiences of income inequality, housing, and homelessness. One of these analyses presented used data from the Trans Pathways survey to explore the risk and protective factors associated with experiences of homelessness among trans young people. The analyses illustrated high rates of homelessness among trans young people, with an association between homelessness and experiences of attempting suicide. Importantly, feeling supported by family was associated with a lower risk of having experienced homelessness. And this demonstrates the essential and protective role that family support can play for trans young people. Overall, this chapter suggests that the marginalisation and disadvantage faced by LGBTQA plus individuals carry a significant material aspect, which profoundly affects their health and their well-being. Not yet, Ash. Among the LGBTQA community, trans and gender diverse people, cisgender women, bi plus people, those with disability, and those living in non-metropolitan areas faced even greater economic disadvantage. Okay, now you can. Thank you. There are a number of analyses presented in the report that demonstrate the importance of supporting and affirming young people in their identities. As an example of one of these analyses, we used data from 1,697 trans and gender diverse young people, and we asked, is feeling supported to affirm gender associated with better health and well-being outcomes among trans and gender diverse young people? And the answer was absolutely yes. Those who said that they felt supported to affirm their gender, whether that was medically, legally, or socially, and that felt supported as opposed to reporting being either denied, delayed, or controlled access to these forms of gender affirmation. So those that felt supported were less likely to report suicidal ideation or attempts. They were less likely to report psychological distress and more likely to report greater happiness. They were also less likely to experience or have ever experienced homelessness in their lifetime. and they were less likely to be subject to verbal harassment in the past 12 months. So the findings from this analysis tell us that it's not just the act of affirming one's gender identity, whether that's legally, medically, or socially, but also the act of supporting trans and gender diverse young people to affirm their gender in these ways that has such a profound impact on their well-being. Next. So in the chapter dedicated to experiences of general healthcare, we included analyses that explored experiences of respect within healthcare services among LGBTQA plus adults from the Private Lives 3 survey. Findings from these analyses demonstrate a clear preference for either mainstream healthcare services with a reputation of LGBTQA plus inclusivity or population-specific services, so LGBTQA specific service provision. Participants were also more likely to want to use a service if it had received a formal accreditation of working with LGBTQA plus patients. However, the vast majority of participants had accessed mainstream services with no reputation of LGBTQA plus inclusivity, and this reflects the lack of availability of both population-specific services as well as mainstream services that are inclusive of LGBTQA plus populations. Those who had attended a service that was either an inclusive service or catered specifically to LGBTQA plus people were unsurprisingly significantly more likely to feel that their sexual orientation or gender identity had been respected. And this chapter more broadly provides evidence that even when the health concerns of LGBTQA plus people are not directly related to their sexual or gender identities, identity affirming care is essential to their healthcare preferences and experiences. The chapter also highlights uneven access to identity affirming experiences within healthcare contexts among LGBTQA plus subgroups, with trans and gender diverse individuals reporting lower levels of respect even within mainstream services that were known to be inclusive. Next, please, Ash. One of the final chapters of the report is dedicated to various intersections of the community in order to illustrate unique challenges and experiences of intersecting identities. And one of these analyses presented in the chapter asks the question, do LGBTQA plus young people with a disability who feel safe and connected within LGBTQA communities experience better mental health and wellbeing outcomes? These analyses drew on data from 2,435 LGBTQA plus young people with a disability from the Writing Themselves in 4 survey. We found better mental health outcomes, including less psychological distress, less suicidal ideation or attempt, and greater happiness to varying degrees among those participants who felt part of the LGBTQA plus community, or they felt that the voices of those with disability were heard and understood within the LGBTQA plus community, or they felt that their LGBTQA plus identity was supported by peers with disability, or they felt that their identity was supported by the NDIS or disability support providers. So these findings illustrate the role of intersecting identities and experiences, but also show the importance of connection and support from others. And for those with disability, it's important to have this support and connection coming from both the LGBTQA plus community, as well as peers with disability and disability support services. That's the last one for me. I'm going to hand over now to Shaq, who's going to present some amazing data that we have in the report on Aboriginal and Torres Strait Islander people.
Amazing, thank you for that. So like Nat mentioned, I'm going to be speaking through the Aboriginal and Torres Strait Islander chapter in the report. Up until recent years, there's been very little health research specifically identifying Aboriginal and Torres Strait Islander LGBTQA plus people. It's something of an invisible intersection within a lot of the health literature. So this chapter is really, really exciting, and I'm very privileged to have been a part of it as contributing new evidence to an underrepresented intersection within the LGBTQA plus community. I'd also just like to acknowledge that I'm presenting from Noongar Whadjuk Budja and pay respect to Whadjuk elders past and present. Next slide. So the findings from this chapter primarily come from 2 places. The first is the Walkern Katatdjin National Survey, which was a survey specifically for Aboriginal and Torres Strait Islander LGBTQA plus young people aged 14 to 25. As a survey that was specifically targeted to this population, it was able to include questions and measures that are specific to the unique experiences of Aboriginal queer people. The second place that the data comes from is the disaggregated findings from trans pathways, private lives, and writing themselves in. So as Aboriginal participants within these larger LGBTQA+ studies, what we can do from this is see how the experiences of Aboriginal and Torres Strait Islander people differ from their non-Indigenous counterparts. So between these two different data sets, we get to build a really rich picture of the experiences of Aboriginal queer people. Now I can go to the next slide. So the chapter covers demographic information about Aboriginal and Torres Strait Islander LGBTQA+ people, relationships, families, and children, the things that made young people feel good about themselves, experiences of affirmation and discrimination specific to Aboriginal, trans, and gender diverse people, and then health, wellbeing, and healthcare experiences, which is what I'm going to dive into now. Next slide. So first up, we were looking at social and emotional wellbeing, specifically using an Aboriginal approach. So this was Graham Gee's model of social and emotional wellbeing that considers an Indigenous perspective on health and wellbeing by looking at 7 different domains of connection. So connection to mind, body, family, community, culture, spirituality, and country. This is from the Walkern Katatdjin survey. And what we saw was that overall, better social and emotional wellbeing was associated with acceptance from parents and caregivers, acceptance from community, and being proud to be Aboriginal and Torres Strait Islander. Additionally, acceptance from siblings, elders, and other family members, pride in being queer, and positive media representation were all associated with other domains of wellbeing. So they all point out these really unique protective factors that can help support Aboriginal young people. Next slide. Now, just as a bit of a backdrop to the next analysis, what we saw from Walkern Katatdjin and what was really echoed in Writing Themselves In and Private Lives was a very high prevalence of high or very high levels of psychological distress. The fact that nearly half of participants in the survey had attempted suicide at some point in their lifetime, and also a very high rate of depression, generalized anxiety, and social anxiety among young people, which is obviously very alarming. We've really theorized that this is the result of intersecting racism and homophobia, biphobia, and transphobia. So within the analysis, we've been able to dive into that relationship a little bit more. Next slide. So this is an analysis from Private Lives 3, looking at factors associated with mental health outcomes among Aboriginal and Torres Strait Islander LGBTQA+ adults, and how this compares to their non-Indigenous counterparts. What we saw was that compared to non-Indigenous participants, Aboriginal and Torres Strait Islander participants in Private Lives 3 were more likely to report suicidal ideation or a suicide attempt in their lifetime, and high or very high levels of psychological distress. Additionally, Aboriginal participants were more likely to report experiencing verbal abuse, sexual assault, social exclusion, and unfair treatment on the basis of their gender or sexual orientation, which seems to indicate that Aboriginal queer people were experiencing more homophobic, biphobic, and transphobic discrimination than the non-Indigenous LGBTQA+ people, which was an interesting finding. Additionally, these experiences of abuse, assault, and exclusion were themselves associated with higher psychological distress and more likelihood of a suicide attempt in participants' lifetime. Next slide. Now, we know full well that the experiences of trans and gender diverse people can often be very different to their cis sexuality diverse counterparts. So using a study from Walkern Katatdjin, we looked into considering how the experiences of cis and trans Aboriginal people differ in terms of their mental health, their social and emotional well-being, and experiences accessing services. So what we saw from this study was that compared to cis young people, trans Aboriginal and Torres Strait Islander young people were more likely to report high psychological distress, a suicide attempt in their lifetime, or experiencing suicidal ideation in the last year, and were also more likely to report lower social emotional well-being on several domains, specifically connection to culture, mind, body, and family, which may very well be the result of transphobic discrimination. Additionally, what we saw was that trans young people were more likely to report experiencing discomfort or discrimination when trying to access mainstream health services or Aboriginal community-controlled health organisations, or ARCSHS, and that they reported that staff in mainstream health services had a generally lower knowledge about how to provide appropriate care for them as Aboriginal trans young people, pointing, I think, to this real need for improved trans inclusive practice, not just in mainstream services, but that needs to be translated as well into Aboriginal organisations who really need to be involved in this conversation. Okay, final slide. Or not. I will now hand over to Julie to talk through some of the findings from SWASH.
Thanks, Jack. I'm happy to cede the floor if you have a bit more to say. I'm really excited actually about this session, and it really speaks to the way in which the different data sets that have all come together have all been generated in community engaged ways. And so that really speaks to the way in which the kind of individual personalities of them and the kind of priorities in each of them reflect the individual communities. And so the power of being able to bring that together into one setting and hear about the kind of some of the commonalities as well as the particular kinds of differences that are emerging, I think is really powerful. As I'm going to talk about SWASH, and SWASH, I guess most people might know, is a periodic survey of the health and well-being of lesbian, bisexual, and queer and other non-heterosexual identifying women. And it's an indicator study. So we do it every 2 years on kind of 2 pieces of paper. So it's kind of quite high level questions that we're asking that are really speaking to particular kinds of health issues that we're concerned about in among LBQ women. And I think the particular thing that this brings is looking at the intersection of sexuality and gender in terms of looking at particularly women's experiences. And so I guess for SWASH, we're looking at 2022 data, which was generated just after COVID lockdown opened up again in Sydney. And so I think that's a particular context for some of this data. We have 2,860 LBQ women and some non-binary people participated in the study. This data is just going to look at women's experiences. Thanks, Ash. You're doing great. So there's 4 things I want to talk about. So mental health, and in some ways the data here reflects what it is that you've already heard from Nat and Shaq, but with that particular focus on LBQ women. So a significant proportion, so 59%, reporting high and very high levels of psychological distress. And the scale there is speaking to acute distress. So it's the experience in the last 4 weeks. And we kind of see that reflected, that level of distress, in terms of questions like ever having felt that life isn't worth living. So that was 35% in the preceding 12 months, and 16% reporting that in the past 12 months that they had done something that to deliberately hurt themselves or done something that they knew might harm or kill them. So I think that particular, that's not news in terms of what we see in the literature and what we've heard today from Nat and Shaq. I think we can also see that particularly in what you were talking about there, Nat and Shaq, about young people. So in SWASH, we also ask a question about mental health diagnosis. So 70% had received a mental health diagnosis of some kind, and 87% had accessed a mental health service. And those are very high numbers in terms of accessing services. And so we were interested to look at that in particular. Next slide, please. So we asked a question around what factors are associated with psychological support seeking among LBQ women in the past 5 years, with a focus on women in the sample who had experienced suicidality or self-harm. And so what we're seeing here is incredibly high rates of engagement. So 91% of people who we have considered needed some kind of access to support had accessed mental health services in that time frame. Now, we don't know about the direction in which this went, so they may have accessed the event at which they may have experienced suicidality or self-harm may have preceded or followed the mental health service. But looking at that kind of engagement, I think, is really positive and very different to what we've just seen in relation to writing themselves in, where I think it was about 45%, I think was the number that you said, Nat. So we also looked at what was associated with seeking services. And so people who had reported to us that they had a disability or long-term health condition were more likely to have accessed mental health support in that context. And I think there's 2 things to say about this. And one is about 50% of the sample reported a disability or long-term health condition in SWASH, and a significant proportion of them, it would have been a mental health condition that they were talking about. But it also speaks to the possibility that people with a disability or long-term health condition are better connected into health services, and so that might be what it is that we're seeing there. But I think that the data that you're getting from all of us is telling a very particular picture around this. Next slide, please. I've been talking about smoking in relation to SWASH for actually over a decade. I went back and had a look. And so in some ways, this is really great data to be showing you. So 6% of the sample, so this is the whole SWASH sample of women, 6% daily smokers and 6% smoking on a less frequent basis. So that's 12%. It is impossible really to overstate the change that we've seen over the past decade. So we're moving from over a third of LBQ women, and I think it was 45% of younger women smoking 10 years ago, to what we're seeing today. It's still higher than what we see in the general population, but that's a really profound change. 25% ex-smokers really speaks to something we need to remember about the ways in which the kind of ongoing burden of disease that might be related to that smoking is something that we're going to see in this population that we need to remain conscious of. And of course, 12% of smokers still means that 12% of people are taking up smoking. So this is not something we want to take our eye off the ball, particularly conversations that we're having around smoking and vaping and the relationship there. So we always find, and again, we do hear, about half of smokers would like to reduce their level of smoking or quit. So we looked at what were the factors associated with smoking, and there were no demographic associations. And I think that's really interesting and a shift from what we've seen in the past. And you'll see something different when we look at vaping in a minute. Smoking was more likely among women who reported lifetime other drug use. And also among women who were reporting concerns around their alcohol use or around their other drug use. And I think this really speaks to polysubstance use, which is a particular feature that we see among LBQ women in particular. That is something that we really need to be paying attention to, and thinking about the ways in which the kind of relationships between those different substances and how they might have kind of interdependencies in terms of use, and what it might look like to actually support women to change their substance use globally, and not necessarily doing one at a time. And so really looking here at the concerns around alcohol use and other drug use might also speak to the kind of way in which a lack of access to social contexts in which people were usually using those substances during COVID lockdown gave people time to reflect on their use. I think that was something that we've heard about in a couple of different contexts. Next slide, please. So in relation to vaping, so again, this is the whole sample of women. 51% had ever tried or used vapes, and it's worth saying that that was 27% 2 years before. So this is a dramatic change in vaping, which of course reflects what we're seeing in a general population. In 2020, it was 1% were daily users of vapes to 10% of daily users. So kind of looking at the way in which vaping is overtaking daily use in smoking, and thinking about, certainly a question we kind of get asked, is vaping the new smoking? And I think it's a bit more complicated than that. Again, when we look at what are the factors associated with vaping, so we're seeing it much more likely among younger women. More likely among women who were reporting lifetime alcohol and other drug use, and that again speaks to that polysubstance use I was talking about earlier, and more likely around women reporting high or very high psychological distress. And that used to be the pattern we saw around smoking. So really thinking about linking here to our understandings of the kind of drivers of smoking, and in particular the way we think about minority stress and the way in which people use substances as a coping mechanism for dealing with minority stress, and that might be something that we're seeing much more now around vaping than we are around smoking. And again, we see concerns around their alcohol use in the past 12 months, as I think there's a real need to do some thoughtful and some nuanced work with LBQ women around vaping in relation to that kind of broader context of higher smoking and higher other drug and alcohol use that we know very well in our communities. I think the final point here around people were much more likely to be vaping if they were smoking. So kind of there's always a question around whether that's parallel, it's kind of dual use, or whether people are using vapes to try and reduce their tobacco use. And certainly there's some evidence of that, because we know that people who were smoking and vaping were also much more likely to say that they wanted to quit smoking. Again, I think there's some tricky stuff there around understanding how successful that is for people or not. So I think from a healthcare provision, healthcare promotion perspective, really understanding some quite complex things around different kinds of substances and how they might relate to each other for LBQ women. Next slide. Thank you. I have to talk about sexual health because that's where SWASH came from. I think that this is particular data which SWASH offers that we don't really get anywhere else in terms of community survey context in Australia. So that's looking at in the SWASH sample, 59% were in a sexual relationship with one partner. I think the really important message that comes out of the 2022 data in particular is the experience of sex with a cisgender or trans man was a majority experience. Now, we've been saying this with SWASH data for a very long time, but I think it's really important to say it in lots of different contexts, and that proportion is increasing. So 2022 data really looks quite different to 2020. So it's really important that sexual health providers and sexual health promotion recognizes and speaks to a majority experience, which is a history of, and for many, a current experience of sex with cis or trans men, regardless of what people's sexual identity is. And so really needing to be careful around assumptions in relation to that. So of course that raises questions around sexual health. So 52% had never had an STI test, or were uncertain if they had. 60% had never had a HIV test or were uncertain if they had. And I think this is a one way in which we really see a difference between the conversation we'd be having if this was data about gay and bisexual men and men who have sex with men. We know what we're aiming for there, whereas I think when it comes to LBQ, and we don't know what good numbers look like. So is 52% never having had an STI test or not sure, is that good or bad? I mean, I think it's probably not great, but we don't have a good agreement around that. I think the final two pieces of data there, 34% had never had a cervical screening test or were uncertain. I think that's quite a big deal. And I think there's quite a lot of work happening in terms of health promotion and changes around that. And 41% had not had any doses of HPV vaccine. Now, that's quite a surprising figure, given that HPV vaccine is given in schools. And there really is no work kind of being done in that particular area. And that speaks to a lot to what might be the ongoing burden in relation to cervical cancer. Last slide, please, Ash. So that kind of brings us to a question of, I mentioned what does good look like? So we asked a question, are LBQ women who should be seeking STI and HIV testing getting tested? And our should here kind of became around sex with men who have sex with men. So 32% of LBQ women in SWASH had ever had sex with a man who has sex with men. Again, we've been saying this for a while, but it's kind of hard to get visibility around this. And it's kind of not surprising if you think about where your sexual partners come from. They come from your social networks, right? So who are LBQ women socializing with? So a third of women have ever had sex with gay, bisexual and queer men. One of the things that we looked at was around STI and HIV testing. So what's great to see here is 81% of these women had ever had an STI test and 64% had ever had a HIV test. So much more likely if people if women had had a male partner who has sex with men. So I think that's good news. And I think it really speaks to, in particular in the SWASH sample, which is metro, highly educated and probably reasonably good access to health services, that where people have the opportunities, they're being proactive. This particular sample anyway is being proactive around their healthcare. Handing it back to you, Ash.
Thank you. Thanks, everyone. That was fantastic. And we whizzed through that in the time that we were allocated, which is great. Now, I think this is possibly the missing slide that Chikara was looking for. I'm happy to talk to it, Chikara, or do you want to?
You're welcome to, or you're welcome to skip over it.
So writing themselves in, private lives and trans pathways have, the authors have been trying for a long time now, for years, to get ethics through, to look at the Aboriginal and Torres Strait Islander data that's contained within those surveys. And that's really tricky. We went to all the Aboriginal committees to ask retrospectively if we could examine that data and report it specifically. And then we've been working with a governance group out of ARCSHS and of Aboriginal and Torres Strait Islander people, queer people, who have been advising us and guiding us. So we're very close to releasing the 7 fact sheets that look at who Aboriginal and Torres Strait Islander LGBTQA plus people are, relationships and families, feeling good, trans and gender diverse experiences, mental health and suicide in young people, and again in adults, and educational experiences. So those have now been finalised and will be released soon. I guess just to say to everybody that I think that what's been done here is pretty incredible, and we've managed to pull together so much, and we really hope this resource is something that can be used by your organisation and your communities to advocate for where funding is needed for your needs. The report, if you haven't seen it yet, can be downloaded from the ARCSHS website, or you're welcome to email any of us to flick you a copy. I just want to acknowledge before we end all the different authors. So while this team and a few others, and led by the tremendous Adam Bourne, did this report, there are a whole bunch of authors who contributed to the other surveys, and we'd like to make sure that they are acknowledged. So what I might do is thank everyone again, pass it back over to James, and we can take questions.
Thank you, Ash. And thank you, Julie and Nat and Shaq, for that incredible quick whip through of a report that is quite large, has enormous amounts of detail in it. So I'd certainly encourage everyone to go and have a look and find out more of what's in there. Please put your questions into chat. They're starting to appear now. So I'll go to the first one which came through, and this is perhaps to any of you who might have some information on it. Is there any research around TGD people within the maternity space, or is there a plan to? And while you're having a moment to think about that, just to let everyone know, we'd normally take about 45 minutes for our webinars. I think with the enormity of this report, we'll make sure that we have a bit of time for some questions. So I'm suggesting we might run another 10 to 15 minutes to allow time for those questions. Okay, over to you, Ash, Nat, Julie, or Shaq. Anything in the TGD space about maternity?
Now, I don't know, certainly we don't have it in any of the big surveys that we've examined here. I don't know if there is any large data collection going on in the space. Maybe somebody else knows. I know that there is someone in Western Sydney University that is maybe doing some work around breastfeeding. But, you know, I always kind of worry about whether it's being TERF-led or not. So we shouldn't say that on the webinar, but I'm going to get myself in trouble. But I think, yeah, I know there is a little bit of work out on breastfeeding, but I don't know of anyone else who's doing that kind of work. But I think it is really important, and I think we would probably be starting with more about a qualitative experience of people, because I think really not very much is known.
Thank you, Ash. Any further comments? We'll go to the next question then. There's a big thank you at the start of the question, but the question comes down to wondering if there are any findings from other specific cultural groups highlighted in the report, responding to the specific information in here about Aboriginal and Torres Strait Islander people. Was there further findings of other specific cultural groups?
We do have in the in one of the chapters that I spoke about, there's a chapter on different intersections of the community, and there's specific intersections that I looked at in that, and one of them is different multicultural backgrounds. I think that's correct, isn't it? That's in the report. It's hard to look at one specific culture within our data because it's so diverse and the sample sizes get quite small. But there is some stuff in there sort of broadly looking at people who come from different multicultural backgrounds. I think possibly, I can't remember, the report is so big, I can't remember exactly what's gone in there, but possibly in comparison as well to those that are not from multicultural background or a culturally diverse background. So there is some stuff in the report in the intersectional chapter.
I'll just add to that. I don't think we ask that very well in Australian surveys. I think what happens is we tend to ask about people's ethnic backgrounds, and the data is really just quite difficult to categorize and to pull out in a way that we can be sure that we are representing people's cultural heritage or their population. So I think there's quite a lot of work that needs to be done around how we do that better. In a place like the UK, they tend to do it really quite well, and they have really discrete categories, but I don't feel like we do it so well in Australia. But I think that really speaks to something we need to be doing more of as we go forward with these surveys. And, you know, there are hopefully going to be more iterations of most of them.
Thanks, Nat and Ash. Question regarding reproductive sexual health. Is there any data information about trans men and menopause?
In some ways the answer is no, but I think there is starting to become some work. So Karen Drysdale and Christine Newman and colleagues at UNSW recently held a roundtable around kind of queer menopause, and so I think that's a conversation that's starting to happen and kind of bringing people in, and that's kind of happened in a broader context of work that again they're doing at UNSW around beyond women's health. So trying to find ways of kind of, I guess, queering both in terms of sexuality and gender, about the way that we think about the way in which we think about traditionally women's reproductive health, and so I think that kind of work is starting to happen, but I'm not aware of any particular data of it in Australia.
Thanks, Julie. Particularly important question next, and if I can, I'd like to make a brief observation first. When Adam Bourne, who's the director of ARCSHS, launched this report at our Health Indifference conference a few months ago, one of the observations that he made at the time was there are services and there are ways to support and provide responses, but they're just lacking the scale that is needed to make a real difference. And that one of the biggest findings he took from this report was the need to scale up what is available. On that intro, the question says, understanding it's just one piece of the puzzle, how do you see the findings within Rainbow Realities translating into the LGBTQIA National Health and Wellbeing Action Plan?
Look, I can probably speak on this because I was on the committee. I'm not anymore. So if there is somebody who is online and is still on the committee and can say that, that might be useful. But look, when LHA was in discussions with the government about data and use of data, there was some discussion about trying to collect more data about experiences before the plan. And as I said, we just have so much of it that it was decided that it was much more productive to use our time to analyse the data we already had. I'm assuming that it will be used to look at the gaps and, as James said, to kind of inform where we need to target funding. But, you know, I guess we never know what government does with results. And from our perspective, we hope that it has been useful to highlight where funding needs to be allocated as the plan goes forward.
Thank you, Ash. If I can also make a related observation on it, there are 10 themes and strands in Rainbow Reality where the information has been pulled together. And while there are other issues outside of that, I think that those 10 issues are going to be very strong pointers to what needs to be tackled in the action plan. And I certainly hope the government is listening as it does its drafting. We now have another question, and Shaq, I think this one might be for you. Wondering if there's research about how well LGBTQA plus LGBTIQA plus community-controlled services provide culturally safe services and support to First Nations, trans and gender diverse young people, and what are elements of best practice and how to do this better?
I can absolutely answer that. So in Walkern Katatdjin, we saw that about 20% of participants were accessing LGBTQA plus services, which is the least access service type, and we know that certainly they can be less available in certain locations, particularly regional and remote areas. But what we saw from Walkern Katatdjin was that LGBT organisations were generally quite good at promoting themselves to Aboriginal people and just having the flag up and kind of being visibly supportive, but that there was a really, really concerningly high rate of young people reporting that when they accessed the services, they'd experienced racist or culturally unsafe treatment, which at the first instance is pretty unacceptable. Generally, I would really recommend that any organisations that are interested in supporting First Nations people really start to build relationships with other communities on the ground, reaching out to Aboriginal organisations or community members or elders, and really having a good idea of kind of what the community context is a really strong starting point. Additionally, I know from some of the broader qualitative research that there is kind of a sense that the segmenting of Aboriginal services and LGBTQA plus services being quite separate is a general thing that a lot of Aboriginal queer young people critique as siloing apart different parts of their identities. So I hope that sort of gives a starting point for the question, but generally just involving yourself in culturally safe care and building relationships with community.
I think just to add to that, some of the work that we've been funded by the Department of Health to do over here in Perth is to develop guidance for ARCSHS to better support LGBTI people. And I think that some of the findings of those we will kind of also help inform, it's kind of flip it around a little bit. But I think there's definitely work to be done for how we do this better within community-controlled organisation, queer community-controlled organisations, because I don't think we do it very well.
Thank you, Shaq and Ash. There's one more question in the chat that I'd like to pick up on, and then we might move to winding up and closing. It's an observation about LGBTQ people of faith backgrounds. My observation is that they're a high-risk group, but that it's rarely identified in research. Was this considered in any of the research you've been talking about?
There is some of the research that's come out of Writing Themselves In and Private Lives 3 that, I don't know if it's both of them, I think they're not new analyses published in the Rainbow Realities report because they've already been previously published, but they are reported in the report around experiences of suicidality that do pick up on, I think it's religious household for young people if they come from a religious household, and possibly, I don't know if like personal spiritual or religious identity was included in those. But there, yeah, I believe there was an association there between coming from a religious household and higher rates of suicidality for young people.
Thank you. So an absolute thank you to the four of you, and I'd like you to give you just one last opportunity for a quick comment and a question from me that I'm keen to hear the answer to if you would like. Before I do that, I put in our chat a link to our webinar survey, and I'd encourage you to please give a response and fill out our survey and give us some feedback. So quick question, I'll do a whip around. One of the things that I think is so important with this research is it provides solid background to so much that we already know and so many of the messages that we've been trying to say to government for years. But I'm really keen is there something that you found during this piece of work that interested you because it was new and you hadn't thought about it in the past? And did it inspire any new thinking of where you think we should go in the future?
Could have prepared us for this one, James.
Yeah, I think you could have. Ash made a face, so you're thinking about it, and I can say I have a quick answer to this, which is, as I said, SWASH is about kind of headlines and key indicators. We don't ask really anything positive. So really, SWASH can't really speak to kind of strengths and protective factors in relation to the kind of analysis that we do. And I think that's the kind of thing that for me that really comes out of bringing together analyses like this. SWASH is all about risk and can't really say anything. And sometimes that means that SWASH is just bad news stories. And I really like the way the other surveys have kind of been able to tell something more complicated and nuanced and provide kind of opportunities to think about more positive action.
Julie, I think that's a fair comment, but I still don't think we do it enough, and there's still always a focus on the negatives. I still think we've got a long way to go in looking at some of the positive aspects of being LGBTQA+. I don't know if anyone else has another surprise.
Has that given enough time for anyone else to have any final thoughts? Happy to let you off the hook. I know it's a tough question, and you all work with this data so much on a regular basis. And thank you again. Incredible. Pleased to have you. And I think it's a really, really important report with so much in it. And I encourage everyone to follow the link. Simply type in Rainbow Realities and LGBTIQ+ at any time, and you'll find it online. Thank you again. Please fill in our survey. And just a reminder, if there is anything here that's raised concerns for you, you can get support at QLife 1800 184 527 or visit qlife.org.au. Thanks again. Enjoy your afternoon. Bye,
Thanks,
everyone.
James. Thanks, team.